Director of Continuing Medical Education at Penn Medicine Princeton Health. Along with our CME coordinator, Janice Palaio, I'd like to welcome you all to the very first virtual psychiatry grand rounds that is not COVID related. So we're now finally getting back to our more normal schedule, and please watch for announcements of future events that will be coming up. We've got a nice lineup for the summer. Once the COVID crisis has passed, we're gonna hopefully continue webcasting grand rounds and other on-site CME events like this. So I know we used to use the old system. Hopefully we can start using this new system if it works better for people. So before we get started, some quick announcements. First, in order to get CME credit, you need to enter today's codes for EADS, our CME tracking software. And that code is 68G as in golf, LIB as in boy. So that's glib as in flippant. So the code is 68 glib. You have a couple of days to register your attendance and complete the required evaluation. So please write down the code even if you haven't already signed up for EADS. Again, that code is 68 glib. And if you don't already use EADS, please read the detailed instructions that came with the announcement of today's lecture to set it up on your device. And if you're still having issues, please contact Janice Palaio at the medical staff office. This meeting is being recorded and will be posted for your colleagues who couldn't make it today. However, CME rules dictate that credit can only be given for live participation. Note that your microphones are on mute. I don't think our video, I don't think Zoom automatically puts your video on mute or turned off. So please put stop video on your screen if you see yourself, and we can avoid distraction. There's going to be a Q&A portion at the end of this lecture. That said, if you have an urgent question for the presenter or for us about logistical issues, please click the chat button at the bottom of the window and type a message to either myself, David Nathan, or to Janice Palaio. And if you want to ask a question, you can ask it either to the whole group as a general chat, or again, you can just send it to me and I will ask it for you later, about 45 minutes into the discussion. So now I'd like to take just a moment to introduce today's presenter. She has no conflicts of interest to disclose. This is actually her first grand rounds for Princeton House. I certainly hope it won't be the last, because she is really a dynamic speaker and a great teacher in the New Jersey medical schools world. So Dr. Erin Zerbo did most of her, in fact, all of her medical training at NYU, her medical school. Then she did her residency in psychiatry, and she did her fellowships in addiction psychiatry. She came to Rutgers in 2014, and she is currently the assistant professor in the Department of Psychiatry at Rutgers NJ Medical School, and she is the director of the Northern New Jersey Medication-Assisted Treatment Center of Excellence. And today she's going to be speaking on Addiction in 2020, Rethinking Neurons, Emotions, and Harm. So Dr. Zerbo, if you are good to go, please take it away.
Great. Thank you so much, Dr. Nathan, for that lovely introduction. And I'm so excited to kick off non-COVID grand rounds. I'm actually not going to mention COVID during my talk for once. And I have too many slides, but we'll see what we can get through. So we'll start with a little bit of the neurobiology, which I think is a really helpful framework. I've gotten recently much more interested in shame and empathy, and so I think it's really fascinating information for all of us to find out about. And then I do want to try to just say a word for MAT right at the end, because I never give a talk and don't talk about MAT, so hopefully we can do just a few minutes on that right at the end. So when you have addiction, what is happening in the brain? And this is the kind of typical thing that we think about. So the reward pathway is this pathway that starts in the ventral tegmental area and projects to the nucleus accumbens. These are midbrain structures, which are relatively primitive compared to the prefrontal cortex. And basically the nucleus accumbens, when it has a spike of dopamine, that signals to your brain that was pleasure. And in addition to pleasure, they've actually found out with more research, it's also salience and motivation. And so it's this kind of, it's kind of our seeking system in our brain that tells us what should you go toward in your environment and what should you retreat from. And obviously this reward pathway works for natural rewards. So things like food, sex, affection, you get little dopamine spikes in your nucleus accumbens to like kind of tell you how pleasurable and how motivating that is for you. It turns out that drugs of abuse hijack this pathway and they cause what's called a supraphysiologic burst of dopamine. So you get a bigger dopamine spike than you would normally get from a natural reward. And in this system all the time is like this steady dopamine level. So you're getting little spikes for natural rewards and then a really big spike for something like a drug of abuse or alcohol. And what we've kind of figured out is that this whole system is really hedonic tone. So when you get that huge spike in that euphoria, that's what's triggering people to have all that kind of that euphoria that they get when they actually use that drug. At its baseline, your hedonic tone is really your sense of well-being or contentment. And it's not very clear, but it looks like some people likely have a lower set point for this system. And so they might have what's called a reward deficiency syndrome. And these are people that are high risk takers, very novelty seeking. And so it seems like they're kind of never satisfied with regular things. And instead they want to go rob a bank or go beat someone up or kind of get in trouble. And it's possible that those people are looking for higher dopamine activity, that they kind of have lower dopamine activity just at baseline. And there's been some work on certain dopamine alleles. We're very early in this research, so it's kind of a clinical concept that's not being applied scientifically as of yet, but just something to think about, that the set point that you're born with is also going to affect your reaction to these dopamine spikes. And then this is just looking at it a little more clearly from the rat brain. So this is measuring inside the nucleus accumbens. You can see if your baseline is 100%, if you give the rat food, it will spike your dopamine to 150%. Sex spikes it to 200%. So that means that sex with your partner should be better than the lasagna. And if that's not true, then there's something going on. And then if you look at drugs of abuse, it's not wildly different. Morphine is 200%, nicotine is over 200. You can see cocaine is higher at over 300%. So not wildly, orders of magnitude higher, but a little extra oomph as compared to natural rewards. And then you take a look at something like amphetamines, you can see they spike it to 1000%. So amphetamines, out of all the drugs of abuse, are the ones that go most directly to the nucleus accumbens to release the dopamine. And it just causes this enormous euphoria for people. So if you talk to people the first time they ever did IV crystal methamphetamine, they'll describe it almost as a full body organism or orgasm rather. And so I think the point here is that our brain should never be seeing 1000% dopamine in this system. And so people have such a strong flashbulb memory of that because that's something you would never encounter in normal life. So you can imagine how captivating that is for people. However, all that said, these spikes were not able to explain addiction. So before, and this is throughout like the 1980s, Nora Volkow's work, she started to really look at this because at that point, the thought was that addiction is all about pleasure pain. That people who are addicted just want to keep seeking pleasure. They don't want to have delayed gratification, get up and go to work in the morning like the rest of us. They just want pleasure all the time. But Nora Volkow was running an imaging lab, and she had people with cocaine addiction coming in. And as they were coming into the lab, they would say, I hate doing cocaine. It's not fun for anymore. I feel like I have to do it. And back then, we had no explanation for that. Why would someone compulsively use something when they're not even getting pleasure out of it? So what's discovered through her work and through many other researchers is that whenever we talk about these dopamine spikes, this is very acute effects. And immediately your brain has a whole cascade of proteins to try to correct it because it knows that that dopamine spike was too high and your brain is always trying to go back to homeostasis. But the fascinating part is all these proteins that were changed and formed, these were very short-term neuroplastic changes that were only lasting for a few hours or a few days. And so it didn't explain this long-term compulsivity that we see in addiction. And so what more research revealed is that to get to this end-stage addiction, which is what we often see clinically, where people are not getting pleasure from regular things, all this compulsivity, et cetera, it's really an entirely different system that has been activated. And this transition occurs through the glutamate system. So basically, if you use a drug of abuse one time, you're going to get that big spike. That does not mean that you're addicted. You have to do that over and over and over. And once you do those large supraphysiologic spikes multiple times, now you start to get new long-acting proteins that are formed. The common one they talk about in the literature is delta phosphate. And this is a transcriptional regulator that is now going to go to other parts of your brain and start to rewire new circuitry. So the big kind of discovery here was the reward pathway is only about the very beginning of addiction, the part when it's like fun and you're actually getting rewarded for using. The more you use it, the more you're transitioning compulsivity that is completely detached from the dopamine system. And now you're talking about glutamate and other neurotransmitter systems and other types of circuits. And out of all of psychiatry, it's interesting that addiction is one of the areas we know the most about neurobiologically. The other that rivals that would be obsessive compulsive disorder. And so we've had a lot of people working on this. We actually have a very clear idea of many of the different systems. And right now, the problem in our country is access to treatment. It's not a lack of evidence-based treatment. So we actually don't, I mean, it's always good to have more research. We need to learn more, but technically we don't need more addiction research at this time. We need the treatment to get to the people that need it. And we know that in the US, only 10% of people with an addictive disorder actually receive special substance use treatment. So we have a huge treatment access issue. So this is just showing you some of the other areas that are involved. The nucleus accumbens is down here in these more primitive areas. You can see it's right next to the amygdala where your fear and emotion is, the hippocampus for long-term memory formation. And so all these areas get very activated, that you have strong emotions about the first time you use. You have a very strong memory of it. This is very kind of primitive wiring that gets sealed when you're first starting to use. And then up here in the prefrontal cortex, the most important area here is the ACG, which is the anterior cingulate gyrus. And this is the area that is really your willpower and your impulse control. So kind of deciding you want to, not eat cookies because you're going to be on a diet. You're using your ACG when you say no to yourself instead of actually eating the cookie. And what we see with addiction is that you're starting with all these dopamine surges in this primitive area. Over time, that delta phosphate and other proteins are forming. They come up here to the prefrontal cortex, and now they start to rewire circuitry via these glutamate pathways. And unfortunately, what happens is that your anterior cingulate gyrus, which used to have good control over your limbic system, now is much weaker and no longer has that strong control. And so basically you get disinhibition from this ACG area. And really what happens is that the behavior is driven from the limbic system, that you're making these decisions in very primitive cortex, and then you don't have the brakes anymore in the car, that really you're just kind of moving forward because you don't have the ACG to block that and stop it. And on top of that, to make everything worse, because you've been kind of over-activating your reward pathway, basically your dopamine ends up burning out. So you can see here on the control panel, the bright red is areas in that midbrain and that striatum, and there's a lot of dopamine activity for a person that's not addicted. And when you're addicted, you can see there's a loss of the red. People say the colors of life go away. And so you just don't have very much dopamine left anymore. The receptors are downregulated. There's less dopamine available in the cells, et cetera. And so you're using these massive amounts of substances at this point, barely getting pleasure out of it, feeling you have to keep doing it, and you're just caught in this compulsive cycle. And so it's really the perfect storm that makes addiction so terrible for the person experiencing it. They're not aware why they continue to do it, and they're not able to stop themselves because of that loss of prefrontal control. And this is the kind of complicated way to look at it. You can see we have a lot of these systems worked out. So over here in the non-addicted brain on the left, you have a very strong ACC and ACG being interchangeable. So a very strong prefrontal cortex that is basically blocking what's happening in the nucleus accumbens and allowing you to stop your behavior. Whereas here in the addicted brain, you have much more power happening from the nucleus accumbens. And now you have a very shrunken and ineffective ACG that can't shut down that. And so you end up going forward and doing the behavior, which is really the compulsive part of it. There's lots of other interesting things in here. So for instance, this area that got bigger, the medial orbitofrontal cortex, that's actually an area for social cognition. And so it's really fascinating. Some areas get stronger and more connected, some get weaker. It's a lot of rewiring that happens. And social cognition is basically deciding what you want to do socially, who you want to spend time with, who you want to hang out. Is it your friend? Is it your child, et cetera? And in addiction, it's actually rewired in service of the drug. So there's some writers that will talk about a drug addiction as being in love. Fergie actually described her crystal meth addiction as the hardest boyfriend that I ever had to break up with. And so there's a real, almost a romantic loving thing to it. And that probably comes from this whole idea that your social cognition gets wired into this. And to me, that's why you would see a mother who could have been a wonderful mother get addicted and then not care about her child, not care about family relationships when she's in the addiction, because her social cognition literally is rewired to look at the drug as what she needs rather than her social relationships. So I think it's so important for us to really kind of think about this, metabolize it, process it, because we are, just as a healthcare system, we tend to be really terrible to people with substance use disorders. Even many educated doctors I work with, who are fantastic on other subjects, are just really not empathic for people with substance use. And so truly understanding what this means, that our behavior is so biologically driven, and that these people really have all their priorities out of balance at a neurobiological level. And if it was our brain, we would be doing the same thing. I think that's the biggest message here, that like we're able to control ourselves because our prefrontal cortex is big. When it's disabled, you're going to see all kinds of other behavior. The last thing I'll say is the habenula here is a more recently discovered area, and it actually turns out it's the anti-reward pathway. So especially with something like an opioid addiction, people will often later in their addiction get really terrified of withdrawal. And it's very common with opioid use disorder. And we used to think that was just psychological, that they felt very anxious about it because they've gone through it before. But it turns out the habenula gets stronger and more active the later in addiction, and that it actually is associated with physical pain during withdrawal. So it's not just that people psychologically want to avoid withdrawal, it's that withdrawal physically gets more painful. So just a really perfect storm of terrible kind of neurobiological changes that end up making the person really an automaton and just going toward the drug and not able to stop themselves. I like to think about it compared to adolescence in a way, because the same things are happening with the prefrontal cortex. So if you see here in the white circle, as you progress, it's not until age 25 or 26 that your prefrontal cortex is fully myelinated and fully connected. And so I very much think of people with substance use disorders almost as adolescents. You can engage with them, you can have a wonderful conversation, they can be highly intelligent, insightful, and then they can walk out of your office and you're watching them buy from a drug dealer 10 minutes later. And so as a clinician, you can feel kind of upset, and is this person lying to me? Are they saying one thing, they go do another? But that's exactly what adolescents are, if you think about it, right? That their prefrontal cortex operates and is, they're smart and they can have that discussion, but the link to the limbic system is not there. And so they're making irresponsible decisions, they're irrational, you want to shake them, they're, all kinds of the frustrating stuff. And that's exactly what you see in addiction. And if you make that shift in thinking about people with substance use disorders like that, it's so helpful. And you stop blaming them and you kind of get out of the interpersonal agony of it. And what I really do is just approach it as I expect people to relapse. And if they did not relapse, then we celebrate that, we get excited about it, we figure out how we can replicate that. But you really just want to keep things positive because, as we'll talk about in a moment, there's so much shame in addiction. So you really don't need to bring in any punishment or shame into addiction treatment, as kind of the old model is sometimes suggested, because it's just going to create kind of more negative behavior and negative feelings. This is just to remind me to say that all of this has lots of factors going into it. So obviously, addiction runs in families, there's genetic predisposition. They did an interesting study where they had 19-year-old males, and half the group had fathers with alcohol addiction and the other half did not. And they gave them alprazolam. And the men who had fathers with alcohol use disorder in their family had a much more positive reaction to the alprazolam, where a lot of the other group felt dysphoric on it. So even that very initial kind of reaction to taking a substance, that's primed by genetics. And then, of course, all kinds of environmental factors. Who was your peer group? What substances were available in your community? Then you move over to psychiatric issues. Were you self-medicating for anxiety, for depression, et cetera? So all these things kind of go together to decide whether someone is going to use a drug and then progress to addiction, or are they going to use a drug and then kind of lose interest in it and not go toward addiction. And the other interesting thing is you could have two different people, give them the exact same amount of substance. One person would end up addicted and one person might not. And so it's so individual variable that you really have to look at that person's kind of whole picture to figure it out. In terms of the environmental factors that make us vulnerable, the two that come up over and over in the literature tend to be stress and social defeat. And this is, of course, interacting with our genes as well. So people with that genetic predisposition are going to be higher. Stress makes sense because higher cortisol levels tend to make everything worse, all our disease processes, a lower immune system, et cetera. So stress was not surprising to me, but social defeat really was because that's so specific to something social. And this is basically that feeling of kind of being bullied, not having dignity, people not knowing your worth or thinking you're worthy. And it's so fascinating. And that's why I've kind of shifted into really thinking a lot about shame and empathy, because the more I work in addiction, the more I realize it's all about connection and social connection. Johann Hari, who is a somewhat controversial figure, but he gave a wonderful TED talk on connection and how addiction is the opposite of connection. That's really the problem. And the more I work in this world, I think he's really onto something, that people feel rejected societally and socially. They turn to that drug in order to kind of self-medicate and make themselves feel better. And then their biology gets warped to be compulsive about it. So it's really important to look at the social component. I always want to mention spiritual experiences as well. So this is an area that we tend not to talk as much about in healthcare, but especially in the addiction recovery community, spirituality is an enormous part of recovery. And it's really that sense of meaning and purpose. There are many, many accounts of people having a mystical experience, whether it was spontaneous. The guy that founded AA, Bill Wilson, he actually he was in a delirium from alcohol withdrawal treatment when he was at Towns Hospital, and he felt that God came down to his bed and spoke with him. And that was actually the day that he was able to be sober. So ever since then, he never had another drink. Fascinatingly, though, a couple months later, he was traveling on business and he was having strong cravings. And so he actually called someone he knew in the local area through a church group, and their husband was struggling with alcoholism. He went to that person's house, had a 2-hour conversation with them, and speaking and kind of being there for that other person helped him deal with his cravings. And so that's how AA was born. And so he was always a huge proponent that you need that spiritual or that purpose, kind of that mystical thing that gets you to want to be sober. But in order to stay sober, you have to have the social connection. And so that's what AA is all about. And now there are millions of AA meetings all around the world. You can find them everywhere. They're meeting on Zoom right now, etc. So really that social experience is what helps keep people sober. And of course, we have no neurobiological explanation right now how a spiritual experience could enable you to get sober like that. We don't know what's going on in the brain, but that's something that I think we need to really take into account and consider studying. All right, so I will move to shame and empathy. We're going to hold questions until the end. So Dr. Nathan will come back on and we'll do questions at that point. So just thinking a little bit about shame and empathy. I don't know if people have heard of Brené Brown. She's wonderful. She has a bunch of books and podcasts and all kinds of materials online. I really recommend people to check it out. She's a social work researcher, and this was a viral TED Talk that had over 11 million views. She has another one called The Power of Vulnerability that's very good as well. And she really introduced me to this world of shame versus guilt. And so the idea here is that shame is this really painful feeling of not being loved and not worthy, whereas guilt is something that's much more located in the prefrontal cortex and a much more kind of mature response or emotion, where you say, my behavior was not good and I want to do better in the future. That's being guilty about something. If you're ashamed of something, you say, I am bad, I am a loser, and that was my fault. And you can imagine shame ends up being a much more toxic emotion because there's no correction to be done. You're bad, right? She describes this, this story of a little girl being humiliated in a classroom. And you can imagine if that little girl felt incensed by that, if she felt she was kind of wrongly humiliated by the teacher, she would go home to her mom and she would say, Mom, Mrs. So-and-so did this in school today. I can't believe it, and have a whole conversation about it, right? That's a kind of feeling upset and feeling maybe guilty or whatever it is. If she feels ashamed about it, if she feels like that teacher humiliated her and she deserved it, then there's no story there. Why go home and tell your mom, I'm a loser, and so the teacher humiliated me? And so shame tends to be this kind of secretive thing that we don't share with other people because we think it's telling us you're not worthy. And it's really an evolutionary thing, because if you're not worthy as a child, that means that people are not going to shelter you and they're not going to feed you. And so in humans, this activates incredibly primitive evolutionary systems that make us just feel really unworthy and scared. Brené Brown she does a narrative style of interview and then kind of takes out thematic coding from that. And she's found that shame is incredibly contagious, that it lives in secrecy, silence, and judgment, that if someone is in shame and they're interacting with someone, that other person can kind of catch it. She describes this scenario of a client coming into the room and kind of discussing something, or a patient rather, discussing with their therapist, and that the shame will kind of jump off the person, run across the room, and go up and around the neck of the therapist and grab the therapist. That even when we hear a shameful story, we kind of cringe and we're like, ugh, it's like our primitive systems mirror that and react to that, and people want to move away from that and get away, or they want to kind of punish and shame the person back. So it leads to all these interesting interpersonal dynamics. She described a story, for example, of a mom who wasn't able to pay at a gas station, and the clerk he said, I want to hold your wallet and your ring while you go to the ATM. She felt incredibly ashamed by that. And when she got back into her car to drive to the ATM, she slams her door. She's all upset. Her 3-year-old wakes up in the back and is crying. She's driving to the ATM and she just feels consumed by shame and being kind of this loser that didn't have money, that she's a loser mom. And she starts screaming at her child, like, shut up at the child. And this is something that this mother had never done before. So when we get to shameful states of emotion, we act out, we do all kinds of things that we would never do, and then we're incredibly upset about that behavior after the fact. And the reason I'm spending so much time on this is because shame turns out to be highly correlated with addiction, depression, bullying, suicide, really a lot of the major psychiatric things that we deal with. And the group that has the highest levels of shame is violent, incarcerated offenders. And so the people that are kind of the worst in society and have kind of acted out the most, et cetera, they score the highest on these shame scales. And so a lot of inability to kind of navigate interpersonally is probably due to this fact that people feel shame instead of guilt, and then they're going to cause more kind of contention with other people. Guilt, on the other hand, is indicative of much healthier functioning. So there's a very small research on this just in the past few years, but basically shame is very much a part of addiction. And because it lives in the limbic system, I believe that it's activated even just being addicted yourself. And so even if you had an incredibly nice family, a good society, if everybody said, this is a brain disease, don't worry about it, just the fact that your limbic system is running the show, that's going to activate shame in you, because you go to use your prefrontal cortex, it's not there, you don't have the brake on your behavior, and so you just feel out of control. And we've all had tiny things of that, like for instance, eating a whole pint of ice cream and then you're embarrassed, you bury it in the trash, or binging on Netflix, you're up until 3 a.m. So we all have those little episodes in our life where we feel out of control, and you can feel that secrecy associated with it, that you're kind of like, I'm not going to tell anyone, I'm not going to tell my spouse that little secret. That's a miniature version of shame. So imagine your whole life is out of control, you can't stop using, everybody knows, now you're getting to massive amounts of shame, even if people are understanding around you. And the antidote to shame, it turns out, is a very effective one, and that's empathy. And so I wanted to show this short video just to demonstrate the difference between empathy and sympathy. And this is Brene Brown.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
I think that's so beautiful, and I just love that. And it's really an iterative process to kind of work that into your clinical work. And I actually teach our patients this in our groups. The pain pathways go through the DACC, the dorsal anterior cingulate, and that's this area kind of in your top middle of your brain that is your distress associated with pain. And it turns out that's both emotional and physical pain. So that whole idea of sticks and stones can break your bones, but words can never hurt you is completely wrong. In your body, words hurt equal to pain, to physical pain. That's why we say things like, I'm having heartbreak, my heart is broken. Like we have physical, painful reactions to emotional stimuli, so we kind of know that intuitively. And if you have pain and you're able to share it empathically with another person, or rather that other person is empathic towards you and they can receive that pain and really hear it, even if they can't give you advice, they can't fix it, there's nothing that happens except that you shared it and they heard it, the activity in the DACC gets much quieter. And so literally being empathic for another person is acting as a painkiller toward that person. And so that's incredibly important for people to know with opioid addiction, because opioid receptors are incredibly dense in the DACC. And when people take an opioid, it's not only getting rid of physical pain, it equally gets rid of emotional pain. And so those people are depending on a pill now to handle their emotional pain rather than other people. And it's so important to understand that difference between sympathy and empathy, that with empathy, you're really being there with the person. And it's hard because as a clinician, that means you're taking in those emotions. And then you have to learn how to do your self-care. How do you metabolize that? How do you process that? How do you not bring that into the next encounter? That's really the work of a therapist. But just being really clear that you're not just giving sympathy, you need to be with them and hear them, and then figure out kind of where to go from there. And just the act of doing that alone is therapeutic. Get past this. Next one. So in terms of actually showing empathy in a clinical situation, there's the cognitive part of it where you do perspective taking, kind of put yourself in their shoes, you're trying to be very non-judgmental, and then you kind of recognize that emotion. Even somebody that is from an entirely different walk of life from you, I guarantee you they're experiencing all the same emotions you're experiencing, just in different kind of ways and different reactions. So we always can kind of get a finger on that emotion in somebody else. But the fourth step is probably the most important one, and that's communicating that back. And so it's not enough to just hear it and really feel it yourself. You have to indicate to that person with your words and your facial expression that you're really there with them. And that's how they get the feedback that you're truly being empathic. A really fascinating thing I learned was that Botox impairs this process. So if you have Botox in your face, you are obviously making much less facial expressions. And it turns out that other people will rate the person with Botox as less empathic. And if the person with the Botox does a questionnaire, they actually are less empathic. So even receiving information, if my facial muscles are frozen, I don't have those natural reactions that themselves help me feel the emotion that the other person is feeling. So it's almost like a meta level that these things are happening with micro expressions and neurobiology and facial expressions and all these things. And just doing Botox can actually interrupt empathic connections. I'm actually a fan of the Real Housewives, unfortunately. This explains like all of the Real Housewives. I'll just throw that out there. But I just thought really interesting that such a tiny thing can even affect our empathic emotions. Compassionomics was written by the CEO at Cooper, and this basically, he showed there's a whole literature on this, that if you're empathic in your interactions with patients, all kinds of things get better. They actually get more accurate diagnoses, they have decreased hospital stay, you have less burnout as a caregiver and as a clinician, just kind of, it makes everything better, and it actually helps financially as well. So we really should be cultivating compassion for human reasons, but you can also say that you should cultivate it for financial reasons. This is the best way to practice, and honestly, the best way to engage in the world. This is what we're really built to do. I'm going to skip over implicit bias just for time. I do recommend you guys Google and take this test if you've never seen it. It's a really fascinating way where you kind of click through to figure out if you have implicit biases towards certain races, or people who are overweight, or people who are different ethnicity, etc. And let me skip over this stuff just for time. So basically just bringing it back to the addiction side of it to say, when you see somebody that is kind of this down and out, that person, just to think about the deprivation that's occurring for them. When's the last time they had a nice word that someone said to them? When's the last time that someone went to them for advice or asked them for help, right? Where is their dignity as a person interacting in society? And I think so often we get frustrated with these patients because they come into treatment settings and they're entitled and they're demanding and they're difficult and irritable, but they're coming from so much deprivation interpersonally that you really just kind of have to overlook all of that. Be nice to them for no reason at all, and they didn't even deserve it, but you just have to be nice because you have to introduce something positive into that system to start to get something better out of it. So just really keeping that in mind for these people that have kind of strayed so far outside of society. And I just want to say a word about trauma. So trauma is obviously incredibly interwoven into all of this. I should have mentioned it earlier when I'm talking about precipitating factors. So many of our patients turn to substances because of trauma. And this is from the work of Salman Akhtar. If anybody hasn't seen him speak, you should absolutely Google on YouTube. He's a brilliant psychoanalyst. But this was such a beautiful way to break down trauma for me. And he really said it comprises of three things. So something bad is done, something good is taken away, and there's gaslighting. So if you have something bad happen to you, and I think the easiest example is probably disciplining a child. So if you're spanked by your parent, that was something bad happening to you, right? Because you felt physical pain. However, if right after the spanking, the parent sits you down, has a conversation with you, talks about why you did that, even hugs you and kind of reassures you and says, we're going to work on this in the future, etc., you can see that nothing good was taken away and the child was not gaslit. There's not some kind of false narrative happening about the situation. Now imagine the scenario where someone is spanked or worse, beaten more badly, and then they're told, go to your room, and the kid is crying and they're like, I don't care that you're crying, you're fine, just go to your room. Now you've had something bad happen to you, but also the good thing, your parent's love has been taken away from you, and your parent is also gaslighting you by saying your pain doesn't matter and what you're feeling right now doesn't matter. Because a little child feeling that pain and rejection has all these surge of huge emotions in them, and normally you want to work through that with other people and get support from them and reach out, and you're being told, go to your room and shut up. And so you can imagine how incredibly traumatic that scenario is compared to a spanking with good things around it. And I'm not saying spanking is good. I don't think any physical, violence should ever happen toward children. I wouldn't recommend that. But you can imagine there's so many different layers to how traumatic something really is, and that these could also be micro traumas. A child that is sensitive and has a very sensitive temperament could go to a parent and ask for something, and that parent might say, no, not right now, I don't feel like it. And that could be a really small but significant time when the child feels rejected, right? And if that happens 37 times over a week-long period, now you're starting to have real trauma build up. So I think it's so important to kind of dig in for people and find what were those experiences. And often they have really strong memories of this and want to talk about it. I'm going to skip over some of this stuff just due to time. And I just want to talk about harm reduction for a moment. This is a fascinating study. So Bruce Alexander is a Canadian researcher, and his idea was that over here on the left, this is how we measure the dopamine in the nucleus accumbens, for example. We put rats in cages and then give them water with morphine in it or whatnot, and often they will get addicted and drink themselves to death. And he said maybe it's because they're sitting in a cage by themselves rather than effect of the substance itself. And so he created this idea of a rat park where you have all the rats together in a social space, and then take a look at the addiction rates, and what you find is that they drop drastically. And so when rats are able to have social connection and other things in their life, they were 19 times less likely to drink that amount of morphine. And so really the same thing for people, of course. Someone once said to me, this means that we have to build more parks. I was like, not exactly. But the idea is increasing social connection. And this is a perfect example of that. So this is Insight in Vancouver. They've been operating since, I think it's 2001, so for years. And this is basically a safe injection facility. So you're allowed to bring any illicit substance into here, and there's no police involvement. It's kind of a safe space for them. And then they'll provide paraphernalia. There's personnel on site. If anybody overdoses, you have, a clean area in which to inject, etc. And what they find is that people feel much more dignity, much more likely to engage in treatment. It does not increase injection drug use among other people. These are people that normally would be injecting in a McDonald's bathroom, et cetera. And one of the founders of Insight came to give a talk last year, and I thought it was so fascinating the way he broke this down. So DCR is a drug consumption room. Before that, the person is kind of buying heroin on the street, hiding from the police, using puddle water, just kind of this really outside of society lifestyle. After a drug consumption room, instead, they're buying heroin on the street, but they go to a hygienic place. They're under supervision of professionals. They can relax, take a shower, have a conversation with someone. You can imagine how that experience of that day is going to be much more likely to put trust in the system, bring them back into society, instead of just kind of they're out dealing with all these illegal things and getting in trouble all the time. So it's really important and a very evidence-based to take this harm reduction approach and help support people where they are rather than continuing to punish them all the time. This, of course, leads into this idea that the drug war itself is completely racist. And I think it's really important to say this in the time of George Floyd and all the things that are happening now across the US. Racism in our country is deeply entrenched ever since slavery. And it's been clear that the war on drugs is very much a war on minority ethnic populations. White people and Black people use drugs at the exact same rate. And Black people are 4 times more likely to get arrested, prosecuted, have longer sentences. The list goes on and on and on. And I think we all know this intuitively, but we've been living under prohibition for so long. It's been over a century in this country that we tend to think of all these solutions on the very far right end of the spectrum. So it's all about how to make things illegal, how to stop it, et cetera. And what you really get to, and I don't know if I put this in here, this is Global Commission on Drug Policy came out with this wonderful report. And it's basically saying that when you make things illegal, you're abdicating the government's responsibility to regulate it. So you basically have this unregulated illegal market, and it causes harm to people. What do we see now? We see fentanyl. And so all kinds of overdose deaths because people don't know what they're buying. Fentanyl is 50 to 100 times stronger than heroin. It's not labeled, so they don't know how much to use. So if that was fentanyl or heroin that they could purchase in a pharmacy and it was labeled, they would know exactly how much to give themselves and they would not be overdosing. So it's not the substance. In toxicology, they always say it's the dose that makes the poison. You're really stripping people of information when you push something to the black market. So just something for us all to think about. And the other thing is when you do push things to the black market, you see these turbo drugs pop up. So crack cocaine, you see moonshine, you see very high THC cannabis. You're really catering to that crowd that wants that biggest bang for their buck. Whereas if you keep something in the legal market, it stays much more balanced. Like look at alcohol and tobacco, not healthy for you, but they're regulated, legal, and available. And so it's a much safer kind of interaction for a person than buying crack cocaine on a street corner. So I know it's 1:17, so I should probably pause there for questions.
Thank you very much. Yeah, no, that's wonderful, and I especially appreciate you putting this in the context of, societal well-being as well as the well-being of the individual who may be living with addiction. So well, first I just again want to thank Dr. Zerbo. We can now begin the Q&A portion of the event, but first I want to repeat the EADS code correctly. For those of you who may have joined us late, I previously stated it incorrectly. The code is 82GLIB. That's GLIB, like in flippant. So 82GLIB. If you don't know what I'm talking about, please refer to the announcement of the event for more information. So to ask questions, we would please click on the chat button at the bottom of your Zoom screen. Type your question there. You can send it to everyone or just to me, and I will repeat the question. We have not gotten one so far, so I'm actually going to start us off. You had been talking about a little bit about safe injection or safe dosing facilities. What do you see as being the future for that in New Jersey here?
Right. So in the US, there's something colloquially referred to as the crack house statute, which means that any dwelling in which anything is happening that's drug related, whether that's manufacturing, production, use, et cetera, that is illegal and needs to be shut down by the police. And so a safe injection site would fall under that because you're allowing people to bring illicit substances in. So currently in the US, there's no federal legal pathway to have a safe injection site. However, Safe House in Philadelphia is an organization that has been working on it, and they've actually gone to court, and they're, as far as I know, the most recent legal decision, which was pre-COVID, was in their favor. So they are trying to move forward. The two women, or I don't know if it's two women, the people that are trying to open the safe injection site have been threatened with 25 years in prison if they open it. So there's real serious consequences to it. But I'm very hopeful that that will have a legal pathway forward, because the data from Insight, and there are other safe injection sites all around the world, all the data show decreased ED visits, decreased mortality. The neighborhoods actually become cleaner because there's not littered syringes on the ground. Car thefts go down in the area in Vancouver. So just like study after study shows that this is a good idea. And there have been millions of doses at safe injection sites around the world, and there have been 0 overdose deaths. And they often use oxygen before they even get out the Narcan, because they're literally watching it happen, so they don't even have to Narcan people. So it's just such a safer way to kind of allow people to use drugs.
Thank you. Our first question is from the audience is, are there any differences in the previously described impacts on the brain based on SOC? That abbreviation meaning?
I'm not quite sure.
I was hoping you would.
Oh, setting of care. Maybe setting of care?
Substance of choice. Oh,
substance of choice. Okay.
Yes. Okay.
Okay. So the different substances activate the nucleus accumbens with different intensity levels. So I think I mentioned stimulants go right to the nucleus accumbens and kind of very directly release dopamine. So you see that huge spike to 1,000%. Whereas something like cannabis actually goes through 2 sets of GABA interneurons. So it's like an inhibition of an inhibition, whatever, to release the dopamine in the nucleus accumbens. And if you look at epidemiologically, rates of addiction for cannabis are around 9%, which is around the same as benzodiazepines. Rates of alcohol is 15%. Heroin and cocaine are in the early 20s. And then, kind of no surprise, the highest and most addictive substance that we have is actually nicotine. So if you smoke 1 cigarette, you have a 32% chance to be a chronic smoker. So obviously there's so many factors that go into this, including societal availability and, you know, how people think about it, how psychoactive is it, all kinds of stuff. But also within our brain, there are different intensities. And then I would say even more so, genetics plays such a big role, that some people will try opioids, get nauseous and sick. Other people try an opioid and they're like, wow, I feel normal for the first time ever. Is this what everybody else feels like? And that's somebody that potentially could have an endogenous opioid deficit. We're not at the level yet where we can throw them in the scanner and say, yes, that's what's going on. But when you hear that story, that's self-medication. So it sounds like it's correcting something internal. And there's some interesting work that Mary Jean Creek did and a lot of idea about this endogenous opioid deficit, but it just hasn't been proven yet. So it was kind of a meandering answer, but basically the substances themselves are a little bit different, and then all those other genetic and environmental factors also play a really big role.
And you are thanked for that answer. Question that I have is about age of first use and its relationship to the likelihood of addiction. And does it vary for different drugs? Is it just sort of, I imagine, well, the statistics show us that the younger you are at the age of first use, the greater the chance you'll become dependent on a substance. But of course, there are many potential confounding variables. Do you see, well, either looking at it in its genetic and environmental context of why people are using when they're 13 versus just an early exposure? Do you see it as an independent risk factor? Does it seem to vary by drug? I'm always interested in that.
Yeah, the vary by drug part, I wouldn't know as well. And I'm not sure if there's literature there to support it, just because it's so hard to do like controlled studies in this area. But I definitely think there's an independent neurobiological impact separating out all the other influences, because as we described, that prefrontal cortex is maturing all the way up until you're 25. And so a lot of the patients that we see with severe polydrug addiction in their 20s, 30s, 40s, the vast majority of them will tell you they started in their teens, and starting around 12 or 13 is really the norm. If somebody starts using something after adolescence, they're much more likely to only be addicted to one single substance, and it's often less severe. So when we see this kind of multi-drug, severe substance use, their life is falling apart, most often those people did start earlier, and it basically does not allow that prefrontal cortex to develop normally. So you get like all this kind of disruption neurobiologically that creates so much more chaos. And the other thing is that emotionally and socially, those people did not go through a normal adolescent development. And so often when they go into recovery, they have the problems peer-wise that young teenagers would have. And that's very frustrating for them, and they don't have the impulse control in the patients anyway, and so it can be really difficult. So knowing when someone started a drug can really give you a sense of, was their neurobiology allowed to develop normally, or do we have a bigger problem because that was interrupted?
Mm-hmm. Great. The next question from our audience is, given that the most common public perspective on addiction and treatment is the recovery relapse kind of dynamic, are there reasons for their, and I'm not quite sure on the wording of this, but I'm going to do my best with it. Are there reasons for there being inadequate education and understanding regarding topics presented today, like brain impact, social effects, et cetera, so that the public may have a more useful perspective that could improve public perspective and response?
Yeah, no, I mean, it's a really great question, and I struggle with this all the time. I honestly think it's all stigma, and I think a huge part of it is the war on drugs. So the fact that if someone comes in with an addiction, they can't reveal that to their primary care doctor. One, it's illegal, so they could lose their children, custody, whatever it is. And two, there's so much shame associated around it. And a lot of that is from the fact that it's illegal, so you're not supposed to be doing it. So that pushes a lot of this into the darkness. And I think the other problem is that being addicted is inherently shameful. And as I mentioned, that shame is contagious. So if you have a patient in front of you that is describing kind of shameful behaviors, and like I think evolutionarily, literally want to distance ourselves from that person. We're kind of like, they're not part of our tribe. Like they're not going to, if we get attacked, this person isn't helping. They're like intoxicated in the back. It's literally, as a tribe, we push them out because we're like, you're not helping and you're making me cringe. And I don't want to look at the things that I'm not able to control, right? That feeling is yuck to me. And like, I don't want to deal with it. And so I think there is the societal part, but I think there's an evolutionary reaction that we have. And so you have to be educated on this and then use your prefrontal cortex to override that and kind of give the person that empathy and that respect, despite the fact that they're kind of doing all these things, et cetera, et cetera. And I think just this message hasn't gotten out there because, I don't know, humans are just so fickle and they're mad. And we have physicians in the ED that like hate substance users and treat them terribly. So how can we expect a layperson on the street to be informed? And I think the biggest thing that we can do to fix that is honestly to end the war on drugs, end all this craziness, make all drugs legal, and let's try to regulate them. And that includes cocaine, methamphetamine, everything, because the point is it's not the substance. By making it illegal, you're just making it more dangerous and you're just perpetuating all this shame.
Mm-hmm. It's interesting. This is normally we're flooded with questions with our evening events. I think it's partly because of the degree to which you've really kind of pulled together a lot of loose ends on this. I really appreciate the perspective. I've gotten some private comments from people who are saying this is just such a great, fresh approach. And I particularly appreciate the concept of destigmatization, which, again, we all grew up as drug warriors. It's hard sometimes to, not think of this in a stigmatized way. I was just watching a true crime show last night, or no, it was not. It was a medical examiner's show where they talk about different medical stuff. Dr. G, she's pretty smart.
Oh, I don't know that. Yeah.
Yeah, she's great. And so, a couple of these cases, including one I saw last night, the family just wanted to make sure that the person hadn't died anything related to drugs. It was somebody who might have been homeless for a while. And thank God they, at least we know that they weren't taking any drugs, and, they still died. But yet there's this perception in the population that, please let it be the case that, it wasn't addiction because of what that would mean. And I think it's so important for clinicians like you who are in positions of leadership to be really working on that destigmatization. So we are.
I just want to say, isn't it fascinating that in that scenario, you have a family with houses that had an unhoused family member, and instead of saying, oh my God, how shameful it is that we didn't bring that family member into our house, they want to know, was he addicted when he died on the street? It's like, what priority, like, where are we? Like, we're all okay with homelessness. We walk by all the time and see people on the street. Like, our society has just gotten so really individualistic and not about the tribe. And that's really what we have to bring back. And of course, this is in larger economic structures, and I'm not going to get into all that, but we have some major kind of forces that are causing us to disconnect and not be empathic toward other people. And we really have to take that power back and fight that.
Mm-hmm. So thank you so much. We now need to conclude today's event. Before signing off, I want to thank Dr. Zerbo, as well as Janice Paleo, who has been on the call and helping us out with the logistics. And as always, we offer our heartfelt thanks to all the doctors, nurses, and other healthcare professionals at Penn Medicine, Princeton Health, and beyond, to our sister institutions who are staffing the front lines of this hard-fought COVID battle. Their personal sacrifices and professionalism in this time